Okay, I wanted to talk to y'all about Module 7. There's a lot of information in Chapter 2. We will revisit a lot of this information in 692, 592, 692. So we will hit the highlights now, but you will go over all that in detail, hopefully in 692. If I'm not teaching it, somebody else will, I'm sure. But let me talk to you a little bit about what I wanted to focus on for this course and for the test coming up. A couple things. Intellectual disability. This is what we used to call mental retardation. It can be caused by lots of factors, and there is lots of that. The first couple of pages of that chapter that gives you lots and lots of reasons. Of course, this should be diagnosed in childhood. But I have seen mild cases not diagnosed for a variety of reasons, and that can be a problem with them later in life. Um, if it's not diagnosed early in life, we've had some patients recently, just I'll tell you a sidebar on this, that clearly has some intellectual disability, and they were not diagnosed as children, and so they didn't get OCDD benefits. And so one man that I can think of right now, his mother cared for him for years, and she did a very good job, and she didn't ask for any benefits or any kind of help, and she did very well taking care of him, but she passed away, and now he's an adult, and we were told because he did not have benefits as a child, then he doesn't qualify for anything now. And those kind of cases, just I don't understand how we could do that, but that's what the state is telling me the rule is. So just keep that in mind when you're seeing young people. If they have some disabilities, we want to address that and treat it if possible. Um, Let me get back on topic. When somebody's diagnosed with an intellectual disability, it can be considered profound, severe, mild. Profound, severe, moderate, and mild. Of course, sometimes when it's mild, it's difficult to address or diagnose. If it's profound, then it's kind of straightforward. Of course, the treatment is going to depend on the symptoms the person is presenting. There's not a medication to cure this, but sometimes we have to give medications to treat some of the symptoms we see. Don't forget about fetal alcohol syndrome. It's in this chapter, and I went to some lectures by a lady up in, I'm trying to think of her name off the top of my head. I can't think about it. She's from Vanderbilt. Susie Adams is her name. She did a lot of research on fetal alcohol syndrome, and she brought to my attention some symptoms we see in adulthood that maybe the child didn't know, or the adult did not know when they were a child, that they were exposed to alcohol. And they don't have severe symptoms, but they do have some mild symptoms. And after going to some of her lectures, I was able to notice it in some patients over the years. So just keep that in mind. Okay, quick few things about communication disorders. Just kind of know that we can have a language disorder, and that is either written or spoken. We can have speech sound disorder, and that is when a patient has difficulty pronouncing sounds, or they say it in a way that's not typical, or it's distorted in some way. And then we have fluency disorders, and that's what we know as stuttering, and that's a disruption in the flow of speech, and so those can be treated with a variety of treatments. In as a psychiatric nurse practitioner, we typically don't do those treatments. We refer that out usually to a speech therapist, but just be aware that those are out there, and we see them in young children often. They're diagnosed in childhood. Autism spectrum disorder. There's lots of discussion about autism recently. There's some discussion on whether or not it's being overdiagnosed. It's officially considered autism spectrum disorder, but it encompasses lots of disorders that we used to separate out, like Asperger's. But what is the diagnostic criteria for these? Generally, what is going on with the patients with this diagnosis is they have a range of impairments in social communication, and they have restrictive behaviors, they have repetitive behaviors. So pay attention to that when we're seeing young people. If they're starting to develop some of those symptoms, we want to address them. It's similar to intellectual disability. It can be severe, moderate, or mild. You'll see some behavior disturbances sometimes, and that will need to be addressed because that can be very disruptive in the family, in the home, with the family, and then also in school. Sometimes behavior modification is all they need. Sometimes they need medication, and they typically use some low-dose antipsychotics, risperidone, Abilify. Hopefully, that won't be needed with the young people. Remember, the onset of this is early development, and so I've been having a lot of young adults come in and tell me that they think they're autistic or they have autism spectrum disorder, and I don't think they do, but I think they're reading a lot online, and they think some of their social anxiety and their social issues is autism, and I don't see that they're meeting the criteria. I was just looking when I was reviewing for this video, the Kaplan and Sadek's latest version said that it is 1% of the population, so that's pretty low, and males are more diagnosed more than females are, and we've been doing that for quite a while. Even though it's a diagnosis that's diagnosed in childhood and it's an early development disorder, it's a lifetime disorder. So, people don't stop having it at 18 years old. Okay, ADHD. We know a lot about ADHD, I think most of us do. I don't think it's new to us. But make sure you look at the diagnostic criteria. The symptoms have to be present greater than 6 months, and they have to have symptoms in more than one setting. In the course of the symptoms, I'm sorry, I was looking at something else. Of course, the symptoms include poor attention, inability to follow tasks through, disorganization. They're very distracted. They can be fidgety. They can be impulsive at times. Take a look at the table 2-15 if you haven't already, and that'll give you all the diagnostic criteria, but a lot of us are very familiar with that already. Make sure you do a thorough exam because a mother or a teacher tells you that the patient has ADHD, that is not always the case. Same thing with adult ADHD. Sometimes patients will come in because they want stimulant medications. They are maybe having some poor concentration, and all of a sudden they say, I have ADHD. They didn't develop it at 30 or 35 or 40 like last week. They may have to develop some anxiety that increased their distraction or their inability to focus, but they didn't develop ADHD. But with that being said, sometimes they're never diagnosed as a child, but they have to have the symptoms before the age of 12 to be diagnosed with ADHD. So I really spend some time with those patients that come in and they tell me, over the last month, I have ADHD and I have all the symptoms, and we spend some time talking about that. Remember, a lot of people abuse stimulants, or they feel like they want to use stimulants to get a lot done, and that's not what that's about, and that's not why we prescribe those. But with that being said, they are the first-line treatment for ADHD, and methylphenidate and amphetamine products are what we use. I mainly see adults, and I use a lot of Vyvanse. There's several formulations of these medications. There's a table on page 136. It's table 2-16, and it has a list of most of the medications. I also use Strattera. It's not a stimulant medication, but when somebody comes in and tells me they're having some difficulty with concentration, or they have a history of ADHD as a child, and maybe they don't want to be on a stimulant, or I have some concerns about abuse, substance abuse, I will start them on Strattera, especially if they're having some some depression. I'll do that, and that seems to work well for them. When you do prescribe medications, the stimulant medications in children, make sure you monitor any growth delays or weight loss. And with adults and children, we need to monitor heart rate, blood pressure, and any EKG changes. I know that was like a real quick summary of that chapter, and it's a lot of information, and you will see that information again, so don't get too stressed out about that. Chapter 13 is about eating disorders. And the ones I want to focus on are anorexia, bulimia, and binge eating. With anorexia, you'll see the food restriction. They're afraid of gaining weight. They'll have a distorted body image, and they're usually low weight. You can have restrictive type or binge eating type. I don't want to say these patients are necessarily sicker, but they do have more complications. They can have some significant medical issues due to their low weight, or they can have some electrolyte imbalances. They can have hypotension, bradycardia, some cardiac changes, some hormonal changes. We have to be careful with them. Sometimes they're hospitalized more so than anybody with bulimia or binge eating. Of course, that's a general statement. I'm not written in stone. We have to be careful with everybody. But with the treatment of anorexia, we need to make sure their nutritional status is stable. We want to make sure they're not dehydrated or have any electrolyte imbalances, and sometimes that will lead to some hospitalizations for these patients. There's not a specific medication to treat or cure anorexia, but there's been some discussion and research on using olanzapine. Of course, olanzapine is known to make people gain weight, and it will help them gain weight. It'll help them probably sleep well, and it'll help stabilize their mood a little bit. We have used SSRI medications and TCAs in the past, not necessarily to treat the anorexia, but to treat some comorbid anxiety or depressive symptoms. Some of them can also cause some weight gain, so that helps as well. With bulimia, we have patients that they don't want to gain weight, and the way they prevent that is they have some type of restrictive. They have they prevent their weight gain by using laxatives or diarrhea. It's late in the day. Laxatives or diuretics, or they have excessive exercising. Sometimes they vomit. Sometimes they'll fast, and that's what I was saying about restriction, but it's not restriction similar to the anorexia. It's more of a fast. And they have to have these symptoms at least once a week for 3 months to be diagnosed with bulimia. Kaplan and Zadig specifically recognize Prozac as a medication that can reduce binge eating and purging. I was reading this information. It was a good reminder that, of course, we need to pay attention to prolonged QT with all the SSRIs, but especially when we're using SSRIs to treat eating disorders. We need to be very careful with that. Okay, binge eating. They have to binge eat at least once a week for 3 months to have a diagnosis of binge eating. And what binge eating is, or what constitutes a binge eating diagnosis, is that they're eating quicker than the average person. They're eating to the point where they feel full or uncomfortable. They are eating without being hungry. They sometimes eat alone because they don't want anyone else to watch them eat the amount of food they're eating. They often get embarrassed about that. And the big thing that with these patients is they feel guilty about what they're eating. And so that's important because that can lead them to some depression as well. So sometimes they don't come to us and talk to us about that, and so we need to make sure we're assessing for that. Vyvanse has been indicated for binge eating, and I do prescribe that on a regular basis for some patients, not a lot. I don't have tons of patients that tell me that. If a patient is losing weight due to anorexia, sometimes it's very easy for us to see that. They come in every 3 months and they've lost another 10 pounds, they've lost another 20 pounds, and we can talk to them about that. But with binge eating and bulimia, we don't always see that fluctuation in weight, and we need to be good at asking those questions. I'll be honest, I don't always do that. I should do it on an initial eval at least, and I'm not as good as I should be with that. Make sure you also assess them for other psychiatric illnesses. if they have an eating disorder, because sometimes they will have some anxiety and depression. Therapy is very important for all of these eating disorders. Like I said a few minutes ago, we'll go over these again in 692, and that's the child and adolescent course, and we'll go into detail in that course as well. We have the elimination disorders. Just a few little things on this. Really, I don't even know if there's anything on the test about it. There may be, but we know these disorders are real. They're not something the child's doing on purpose necessarily. Encopresis is when the child has feces, has elimination of feces in their clothes or on the floor. It can be voluntarily being done or involuntarily or intentionally. But I don't think that the child, I don't want to make it seem like the child is doing it on purpose. And I know that doesn't make any sense the way I said that, but it's not just because they want to use the restroom on the floor. They have some other things going on. They could have some low self-esteem. There's some discussion about it's an expression of anger, but it can lead to some pretty significant conflict in the family. Education is a big part of treatment. They can be given laxatives if there's an impaction and they're having feces around a impaction. So that can be used. Laxatives can be used. And then also, if the patient is urinating in their clothes or their bed, we need to address that if they're 5 years or older. So I don't really have too much on the test that I'm thinking of in this with these diagnoses, and I'm thinking about them as I'm thinking about the test as I'm thinking about my notes on this. We don't see this too much in the psychiatric world. A lot of times this will be treated by the pediatrician. I can't remember any time a child's been referred to psychiatry necessarily just for this. Sometimes they're referred to psychiatry for some behavior problems, and this is also part of the issue. So I don't think it'll be a big part of your practice is what I'm getting at. One thing that, with the next two things I'm going to talk about, can be definitely a part of your practice: oppositional defiant disorder and conduct disorder. These two diagnoses, people get them confused, but the difference between the two is conduct disorder, you usually have aggressive behavior, and you don't see that with oppositional defiant disorder. But oppositional defiant disorder is exactly what it says. The child is oppositional. They do not want to be told what to do. They don't take responsibility for their behavior. They don't take responsibility for their mistakes, and they can also be very hostile toward authority figures, but they're typically not aggressive. Conduct disorder, children with conduct disorder often are aggressive. They're impulsive. They're destructive to of property. They are physically aggressive to other people. There's a table on page 190. It's table 2/R2-29, and you'll see on that list there's lots of criteria that I didn't go put on my notes here, but often they bully people. They are sexually inappropriate with people or force other people to have sexual activity with them. They damage property. They set fires. It's a very serious disorder that needs to be addressed as soon as the symptoms start. Therapy is very, very important with these patients. There is some discussion about antipsychotic medications and Depakote for aggressive behavior. There's some discussion about SSRI medications to manage impulsive behavior and that irritability that can be seen. And hopefully that would stabilize the mood a little bit. These children usually have lots of problems in school. They can sometimes get into some legal problems at a young age. And this is just a side note for just, I don't have any evidence-based practice research to support this, but over the years in practice, the thought has been that if somebody has a conduct disorder in childhood, then they're most likely going to have antisocial personality disorder, and then have a lot of criminal behavior and probably be incarcerated in the future. But when I was reviewing my notes, reviewing Kaplan and Sadek, but in my notes, it says on page 192 that there was a study that the diagnosis of conduct disorder did not correlate to imprisonment in the future. So that's good. Maybe we're starting to address these symptoms very young, and we're preventing that. I hope so. So I know this was a lot of information in the readings, but I wanted to highlight just some things that I saw as I was going over the readings again. And also there is some highlights on I'm trying to remember the exact PowerPoint title. I think it's module 6, 7, and 8 is the title of the PowerPoint that I posted a couple weeks ago. And there's some other information in there. So look at that and go over this video, and you'll do fine for the test. All right. Thank y'all.